Good afternoon, everyone. Welcome to PQA's Quality Essentials today. I'll give it 1 minute to have people log on. So I'm Lisa Hines. I'm Chief Quality Innovation Officer at PQA, and today's Quality Essentials webinar is focused on quality measure risk adjustment. And just some logistics. Send us your questions using the Q&A feature at the bottom of the screen to send the speakers your questions throughout the presentation. And today's forum is being recorded. A copy of the slides and the recording will be shared with PQA members within a week. And please give us your feedback after the webinar. There's a quick survey that will launch at the end. And today we have Ben Shirley, Senior Director of Performance Measurement, and Heather Gibson, Director of Performance Measurement, presenting today. They're going to start with the basics of risk adjustment, walk through some guidance that's been published on risk adjustment, pull in the stratification concept to compare and contrast that with risk adjustment. We'll touch on PQA's risk adjustment recommendations for our adherence measures using sociodemographic status. We'll leave some time for question and answers and close with a few announcements. And I will hand it to Heather.
Thank you so much, Lisa. And so, as Lisa mentioned, before we get into all the fun stuff about what PQA is doing in the risk adjustment space, I just wanted to take a little bit of time to review with you all some of the risk adjustment basics. So let's get right into it. What is risk adjustment? Well, risk adjustment and quality measurement is a statistical approach that ensures measure scores are affected as little as possible by factors other than quality of care, such as differences in patient characteristics. You may have heard of risk adjustment through research endeavors or read about them in the literature. And in research, risk adjustment is often a mechanism to identify predictors of an outcome of interest. And while the methods used in research and quality measurement related to risk adjustment look and sound similar, it is really critical to understand the purpose for risk adjustment. And so why do we risk adjust quality measures? Well, the argument in favor of risk adjustment posits that by not adjusting for social risk within certain performance measures, accountable entities may actually avoid caring for the most at-risk and disadvantaged patients because of their anticipated worse outcomes or higher costs, and that could potentially worsen the inequities we see within measurement. Risk adjustment, therefore, really aims to ensure fair comparisons across accountable entities, encourage providers to care for disadvantaged patients, and really show those real differences in quality of care rather than the differences in the case mix of the population. And so risk adjustment is also just one tool we can use to address health equity within quality measurement. And that really just aims to close the gap when it comes to health equity and not institutionalize or exacerbate it. And so when we're considering the risk adjustment model, the conceptual model is one tool to utilize when deciding whether or not to risk adjust. And we'll discuss that in a bit more detail on the next slide. The other methods that should be utilized in conjunction with the conceptual model include empirical results of the risk adjustment model, expert input, and evaluation of potential unintended consequences. And regarding those empirical results, we should review statistical characteristics of a model such as calibration and explanatory power. Statistical significance alone, though, should not be a determining factor in and of itself. Expert input is equally as important, especially in the case of the statistical input and clinical input really to ensure that the model is constructed appropriately and factors that impact patients are accounted for appropriately. And failing to adequately risk adjust can actually bias conclusions, and the factors that impact the patients are accounted for appropriately. And this can also bias our conclusions that may adversely affect decision making and research or policy and even patient choice if we fail to adequately risk adjust. Another potential unintended consequence is perpetuating disparities in care by reducing incentives for providers to address these disparities. And overall, we really are looking for a balanced and thorough consideration of the pros and cons that are critical to deciding if and how to risk adjust within quality measurement. So I mentioned the conceptual model on the previous slide, but what actually is it? So when deciding on whether or not to risk adjust and what factors to include, the National Quality Forum actually strongly recommends using the conceptual model, which helps us identify which factors could be appropriate for risk adjustment. In essence, a conceptual model helps us understand what factors are related to the process or outcome being measured, and whether those are even under the control or influence of the measured entity. And in this figure on the screen from NQF's most recent final report on the topic, the top blue-gray section represents factors related to the quality of care provided, which may be the focus of the quality measure and should not be considered for risk adjustment. The bottom tan section represents factors that are not related to the quality of care provided, and these factors are present at the start of care. And those are the ones that can be considered within the conceptual model, things such as health status and clinical conditions, patient demographics, social vulnerabilities related to the outcome of interest, one's lived environment, and functional factors related to the outcome. The important here is that the diagram shows that these factors are present at the start of care. And that's when they are appropriate for consideration within a risk adjustment model. And really, that means that the provider is unable or limited in their ability to influence these factors, even though they may play a role in the outcome being measured. And so when considering quality measure scores, you can risk adjust for a number of characteristics or factors, including clinical, which could be certain disease states, demographics, and this relates to some of the factors we discussed earlier, including age, race, sex, social status, which could be income or a geographic region, and functionality, which can include factors that may impact one's abilities to perform daily tasks. And there's more that can really go into this. With respect to demographic and social status, there may be a few different terms used. PQA uses SDS for socio-demographic risk, but you may see other terms used by different organizations. But it's really important to recognize that there are many categories that are influenced by SDOH, which is another reason why risk adjustment can be viewed as one lever towards health equity. And so, how do we select factors to address? Well, there's a lot of considerations that we can use when selecting factors to adjust for within quality measurement. And thinking back a couple slides ago, we want to identify whether there's a clinical or a conceptual relationship with the outcome of interest, so that conceptual model. We can also test empirically to see if there is an association with the outcome of interest. Variation or prevalence of a factor across measured entities is another important consideration for identifying factors to adjust. For example, plans that disproportionately cover more individuals who are dual eligible may have lower scores on certain measures compared to those with fewer dual eligible beneficiaries. And again, we need to ensure that the factors we adjust for are those that are present at the start of care, and that they're not indicators or characteristics of the care that's provided, such as treatment or expertise of the staff. We also need to ensure that the data representing a factor is accurate and can be reliably and feasibly captured. And when it comes to data, an integrity and quality of data is really critical. The old saying of data science applies: garbage in equals garbage out. Inaccurate or unreliable data can really lead us to conclusions about care that are not sound. And finally, we need to consider any unintended consequences that risk adjustment of a particular factor may have. And so going deeper into the data aspect of risk adjustment, there are a variety of data sources that you can use to capture social and functional factors, such as administrative claims. Now, each of these are going to have their strengths as well as limitations, but at a high level, the administrative claims are the most widely used, or at least thought about, data source when thinking in the context of quality measures. They are a really efficient way to capture demographic information for really large populations. However, these data are limited in their timeliness and completeness when you're thinking about things specific to demographics or different populations. For example, race data may not always be self-reported, which is sort of the gold standard for that information. EHRs, or electronic health records, have more clinical data and context compared to claims, and they're really efficient to access since the data are, as the name suggests, electronic. However, these data are not always structured or standardized in the way that they're collected. Registry data is usually the most granular and standardized when we're thinking in the context of capturing social and functional factors. However, there may be a little bit of an increased burden and costs associated with even just participation within a registry. And registries may also not give us the full picture because they tend to be limited to a specific disease or procedure. And then finally, clinical assessment data can give us really great insights on outcomes and treatments that are not prescribed by the clinician because these are like patient surveys. However, these data can be limited due to the patient level barriers and lack of validated instruments with which we can collect this data. And so now that we've covered the basics, what guidance is out there that's being given to others around risk adjustment and quality measurement? And we're going to focus on the National Quality Forum, or NQF, and ASPE, which is the Office of the Assistant Secretary for Planning and Evaluation Reports. And so, those have really been the drivers behind quality measure risk adjustment. That's where we're going to focus sort of our background. And this has really been a very fast evolving field, and a lot of guidance has actually been developed concurrently. So we're going to look at this on a timeline at a high level, and then we'll dive a little bit deeper into each of these. So in 2014, NQF released their first report recommending that each measure be assessed individually to determine the appropriateness of SDS adjustment, and that the specifications for stratification of a measure be included. ASPE released their first report in 2016, which noted that there was a need for enhanced data collection. They also recommended the development of health equity measures and noted that more research was really needed to determine the appropriateness of risk adjustment within quality measurement. And following that initial report, ASPE released a second report recommending that measures should not be adjusted for social risk for public reporting or value-based purchasing programs, and that value-based purchasing programs should really not use peer grouping or categorical adjustments for social risk. NQF released their second report the following year in 2021. And in that report, NQF established some minimum requirements for what should be evaluated within the conceptual model, and also required that measures be stratified in conjunction with risk adjustment. And we're going to talk about stratification a little bit later. And so they followed that report up most recently in 2022 with their final report, noting that while the role of race in risk adjustment was not decided on by their TEP, race as well as ethnicity, urbanicity, rurality, poverty, and disability status should be used for stratification of measure results. And so let's go a little bit deeper into each of these, starting with NQF. The final guidance from NQF notes that developers must, at a minimum, consider age, gender, race, ethnicity, an indicator of urbanicity and rurality, an indicator of poverty, indices of social vulnerability, and indicators of frailty and disability for inclusion during the process of developing the conceptual model. And if the social or functional risk factor data are not available in a data source of sufficient quality, but these factors were included within the conceptual model, then developers should really describe the potential bias that may exist and its direction as a result of not including a factor within the risk adjustment model. And they also stated that developers should provide a justification for why a measure still has validity, even in these circumstances. This guidance also notes that simple bivariate and multivariable tests alone should not determine whether a social or functional factor is included in the risk model. Rather, there's several empirical testing methods that may be used to test relationships that are described within the conceptual model that you develop. And so in ASPE, switching gears, in their first report, they examined dual enrollment, living in this low income area, Black race, Hispanic ethnicity, rural residency, and disability for appropriateness as social factors for risk adjustment. And what they really found was that the social risk factors were associated with worse outcomes regardless of provider. And that really just means that these factors are truly outside of a provider's control. And they also found that dual enrollment was still actually a power predictor for adverse health outcomes, and that this persisted even after risk adjustment across all different settings, measure types, and even across different programs. And so, as far as overall recommendations from ASPE, in 2016, they recommended enhanced data collection to improve the usability and accuracy of social risk factors. They recommended the development of health equity measures in order to address gaps within equity. And they also addressed the need for further research to determine whether social risk adjustment was appropriate within quality measurement. And then in 2020, they added guidance on when to adjust measures for social risk, consideration of stratification of dually enrolled and other beneficiaries. And they also recommended the further examination of the impact that functional status or frailty could have on the relationship between social risk and measure performance. And so, when are we supposed to adjust measures for social risk? Well, according to ASPE, the least appropriate measures are those where the provider factors are the most influential to measure performance, where there really is no plausible direct relationship between the social risk and measure performance, and where the evidence that poor quality is the overall driver for performance. And the most appropriate measures for risk adjustment, again, according to ASPE, are those where patient factors are the most influential on measure performance, where there's a plausible direct relationship between social risk and measure performance, and where there's evidence that a patient need or complexity is really the overall driver for measure performance versus any of the physician or accountable entity level factors. So though there are some challenges that are associated with risk adjustment, and first, maybe one of the most limiting factors, at least in my mind, is that social risk information is not captured in a routine or standardized way within our healthcare system currently. We also know that even after accounting for social and functional risk factors, that dual eligibility and functional status are still our power predictors for poor outcomes on some measures. So, for these measures, is there really any tangible benefit for further adjusting for social and functional risk? And although organizations are working really hard to improve equity within healthcare, we still have so much more to learn in regards to scalability and effectiveness of risk adjustment within quality measurement. And jumping off some of those challenges associated with risk adjustment, let's take a peek at some of the concerns and benefits of risk adjustment, because this is really a balancing act of mitigating concerns so that we can reap those benefits. And starting off with the concerns, there is the potential for unintended consequences when we adjust outcome measures for social risk. Those opposed to risk adjusting for social factors really worry that this could lower the standard of care given to patients with these factors and obscure differences in the quality of care between providers. And further, risk adjustment really only addresses the patient characteristics when there could be accountable entity characteristics that are really impacting the measure performance. So things such as funding of safety net providers, the available healthcare workforce in a particular area, differences in community resources, and differences in economic conditions. And on the flip side, proponents of risk adjustment note that the benefits of adjustment can really help preserve access to care for patients, because otherwise we could be incentivizing providers to avoid caring for those patients at greater risk or greater disadvantage. Risk adjustment can also reduce the likelihood of penalizing accountable entities for patient factors that really truly outside of their control. So now that we've gotten through all of that, I'm going to hand it over to Ben now to discuss the related topic of stratification, as well as what PQA is doing within our own measurement space.
Thanks, Heather. And that was a really good overview of risk adjustment. It's the title of the webinar. We've talked a lot about it. It's a super important area, but I'd like to talk a little bit about stratification, which really in many ways can be thought of as the other side of the coin when it comes to risk adjustment. Stratification really is this very important balancing sort of companion force. So what exactly is stratification is a good place to start. Stratification refers to breaking out rates by different subgroups for a quality measure. So essentially, an accountable entity is going to end up with multiple scores, one for each subgroup of interest rather than just one big overall score. Frequently, these subgroups are going to be based on some sort of social or functional status related factor, although there are lots of different recommendations out there for exactly what you should and shouldn't stratify by. For example, Heather actually mentioned earlier that the National Quality Forum has something to say on this. They recommended a minimum looking at race, ethnicity, geography, so urban versus rural, some indicator of poverty and disability. But really what's important is that you are stratifying by things that are conceptually and empirically linked to the outcome of interest and expected to potentially identify disparities. So stratification, you can really sort of think about it as the ability to shine a light on gaps in care, on potential disparities, and that really then provides organizations with the opportunity to design interventions around them. It's definitely important to clarify some of the differences between risk adjustment and stratification. So risk adjustment still provides one overall score for the entity. The stratification is going to provide multiple scores, one for each subpopulation. Risk adjustment, again, really highlighting those differences in quality of care by controlling for case mix, while stratification highlights differences by comparing across that case mix. So there's a difference there. Risk adjustment typically going to use some sort of fairly complex statistical modeling, while stratification typically a little bit more straightforward of a breakout, although in some cases there can be some adjustment there. But I think when you think about comparing and contrasting risk adjustment and stratification, it really is beneficial to think about it as two sides of this related coin. Risk adjustment is really designed to even the playing field, which is super important for all the reasons that Heather spoke to. You want to avoid this vicious cycle where relatively poor organizations, because they're serving a challenging or a vulnerable case mix, are having poor performance. And because of that, they're getting penalized, right? They're maybe missing out on opportunities to get bonuses or get resources they need to better care for these vulnerable populations. And you can see how that then perpetuates. And those disparities can become ingrained or institutionalized, and it becomes very difficult to break that cycle. That's a really bad outcome. And that's something that risk adjustment is really designed to try to help us avoid. But when you do risk adjust, the stratification helps to also provide that critical transparency. It's the transparency for the healthcare system to maintain a clear understanding of subgroup performance and really understand where improvement is needed. With that on stratification, we can shift gears and talk a little bit about how this affects PQA specifically. Many of you are likely aware that we have recommended SDS adjustment for our adherence measures used in Medicare Part D. And I think it's helpful, first of all, to just to take a stroll down memory lane, if you will, and look at exactly how we got here. Really at the center of this story is this group, the PQA Risk Adjustment Panel, or RAP. So as with all of our measure development activities, this was approached in a systematic, multi-stakeholder and consensus-based manner. And it really relied on this risk adjustment advisory panel to bring sort of the expertise and the insight that we needed to make the best decisions we possibly could with respect to risk adjustment. So this group was convened, bringing together a really impressive group of risk adjustment experts and other methodologists that helped us to think through some of these challenging questions. Really starting with evaluating PQA's portfolio, looking at all of our measures and saying, okay, where do we need to focus? Which measures are maybe appropriate candidates to consider for risk adjustment? And their prioritization was the adherence measures used in the star ratings, partly because of the conceptual link between adherence and certain SDS factors. But another reason that this focus sort of emerged was that these are intermediate outcome measures. So if you remember that continuum that Heather spoke to with sort of which measures are more or less appropriate, you might recall the process measures were really typically considered less appropriate, typically more under the control of a provider or the accountable entity. But outcome measures are starting to migrate towards that more potentially appropriate for consideration angle. And that is certainly something that you'll hear about commonly in measure development in consensus-based endorsement. If it's an outcome measure, has it been evaluated for risk adjustment? So then with that priority, CMS actually contracted with PQA to conduct a study to assess the SDS variables impacts on the measure. The RAP actually looked at a pretty wide variety of variables based on a literature review and a lot of discussion. And they ended up looking at factors really at a number of levels. So not only patient level factors, but characteristics of the community, even characteristics of the county to evaluate how those potentially interact with the concept of quality being measured. And to get, I guess, slightly technical, maybe just for a sentence, essentially what was done was that, the RAP used variables significantly associated with adherence in a multivariable logistic regression model. They then used those values to calculate a risk-adjusted score for each Medicare Part D contract for all three measures separately. And essentially what that means is that PQA and the RAP looked at conceptually related variables, identified which ones are empirically related, and then created a model and scores based off of that. So that was sort of what we might refer to as the full model, but we also looked at a reduced model that was a little bit more parsimonious, meaning it used fewer variables, fewer parameters, and specifically it focused only on patient level factors, really to reduce burden and improve feasibility. Whenever you're drawing in data that's not directly related to a patient, community data, county level data, it can become more challenging for entities and organizations to execute that from a measurement perspective. So we did look at it with a simpler model and did find similar results. So the model performed pretty similarly. And as a rule in statistics, when you can get the same result from a model with fewer parameters, 9 times out of 10, that's going to be a better approach. So that reduced model was ultimately brought through the process. It was actually endorsed by not only PQA, but the National Quality Forum, which really sort of reflects the level of rigor and measurement science that we would expect from things with the PQA stamp on them. Actually, it was reviewed quite in depth, not only by the National Quality Forum, but for those familiar, their scientific methods panel. We discussed and defended the model before them as well. So it really has sort of gone through substantial evaluation and found to pass muster. And so when I'm talking about these recommendations, this is what I'm talking about. So I'm talking about the recommendation that all 3 PQA adherence or proportion of days covered measures, so that's going to be your diabetes, your ROSs, and your statins, should be risk adjusted for socio-demographic characteristics in the Medicare. And more specifically, these measures should be risk adjusted to adequately reflect those differences in patient populations across contracts. They should not only be adjusted for these characteristics, but also stratified. And these characteristics are age, gender, dual eligibility or low income status, low income subsidy status, and disability. And one thing I want to call out here briefly is that you might notice that race is not included here, which is a beneficiary level factor, and it actually is the only beneficiary level factor that wasn't ultimately recommended for inclusion in this reduced model. And this was something that was discussed at length by the RAP. The RAP ultimately sort of had persistent concerns, about the accuracy and completeness of that data source. Heather talked a lot about the importance of data integrity and provenance and the age-old saying, garbage in, garbage out. They were concerned that data, especially data that's not gold standard around race, so that's not self-reported, might not be very reliable. There's also some concern about use maybe of race as a proxy for socioeconomic status. So this was something that was discussed at length by this group before the decision was made in PQA standard consensus-based process. And so why talk about this now? Why the buzz now? Well, that is because there has been some movement around this from Medicare Part D. So for the recent proposed rule, CMS proposes to implement risk adjustment based on SDS characteristics to the 3 star ratings adherence measures based on PQA's risk adjustment. And what we have on the slide here, I think, is sort of a helpful roadmap for you to get your bearings. It shows how this is going to happen. For those familiar with this process, it's certainly not going to happen overnight, right? This is not an immediate process. This is going to be a substantive change, and that means that it's subject to federal rulemaking, which is its own process. It involves federal public comment, processes managed by OMB, and other sort of regulatory hoops or checkpoints that need to be gone through. But ultimately, if this rule is finalized, it's only proposed now, the legacy, and when I say legacy, I mean non-risk adjusted medication adherence measures would remain in the star ratings, as you can see on the slide there, through star year 2027. The updated, and I guess when I say updated, I mean the risk adjusted adherence measures. Those ones with SDS risk adjustment would go onto the display page for 2 years, for 2026 and 27. This is very standard for CMS's process to have new star candidates go through the display page, learn about its performance, give plans a chance to get their bearings. And then ultimately 2028 would be this year when the hinge sort of swings, and the adjusted measures would go into the star ratings. As their first year, they would be single weighted, and the current adherent measures, the non-risk adjusted versions, would then be sunsetted out of the program. So that really sort of gets at what we've done with risk adjustment, how we got there, the sort of current climate, and where maybe this is going in the CMS ecosystem. But I also want to highlight some additional work that PQA is doing to guide us in this sort of broad space of health equity. And what I want to talk about specifically and call out is the PQA Health Equity Technical Expert Panel. So this is a really important group that we're really excited to bring together. That's going to provide us guidance on some specific items with respect to health equity, risk adjustment, and stratification. So in particular, this group is going to focus on the objectives you see on the slide. So identifying stratification variables and methodologies for standard inclusion in PQA measure testing. So we do test for various variables now, but a unified standard approach that sort of reflects the right subpopulations to look at the right time will be a really helpful stepping stone for us to understand how our measures perform in different subpopulations of interest, especially when those subpopulations might be more vulnerable than others. And then going beyond testing, the group will also evaluate and recommend the use of those identified stratification approaches for PQA measures in quality programs. So we don't just want these to be sort of FYI for PQA's internal testing. We'd also like to work with and recommend appropriate stratification in measurement programs beyond PQA's 4 walls. And then finally, we want to talk about the feasibility of risk adjustment. So very much related to what we just talked about, for the PDC composite health plan measure. Risk adjusting a composite measure is a little bit more complex than risk adjusting a single measure, which is already somewhat complex. So we do want to make sure that we have sort of the high octane statistical methodological folks on this panel that can help us sort of guide us towards those correct decisions. So if this sounds like something that you want to be a part of, that's excellent. I have good news for you, because this panel will have a self-nomination process, and that process does open on March 20th. That's this coming Monday. We are specifically seeking individuals with experience in initiatives to promote health equity, quality measurement, statistical methodologies, including both creating and interpreting risk adjustment models, and experience serving patients from diverse backgrounds. And as a quick reminder, this is a technical expert panel. It's a TEP. By their nature, they are relatively smaller, nimble, technically proficient groups, usually around 20 individuals. So space is limited. With that being said, I do highly encourage you all, if you're interested, you believe you're qualified, to self-nominate, to pass along to others in your organization, because getting the right folks on these panels really is sort of the lifeblood of PQA's measure development and maintenance process. And we do really look forward to working with our members to help build out our equity measurement strategy through this technical expert panel. And just to close out, I think it's a good idea to remind everyone that, PQA swim lane is very much measurement, right? But measurement is not all there is to health equity. Far from it. Barriers to health equity are multi-level problems. They're multi-type problems, and they require multi-level solutions from the healthcare. So measurement is a super valuable tool for identifying areas for improvement, for targeting interventions. But ultimately, it's those interventions and approaches and changes to systems that really need to be in place. And those changes need to occur at all levels of the healthcare system, not just the individual, patient-provider interactions, but at the community level, at the county level, federal, all the way up to national, in order to tackle these sorts of equity issues. So when it comes down to it, improving health equity, it really requires an investment of time and capital and passion from across the health system. PQA very much is committed to doing our part, but we acknowledge and understand that we're part of a much bigger puzzle when we tackle these issues. And a lot of other pieces of this puzzle are probably listening to this webinar right now. A lot of them are PQA members or members of other healthcare organizations that are also working on this. So I very much encourage you to think about all the work that your organization is doing. Think about how that dovetails or intersects with or abuts PQA's work, and think about how we can collaborate together towards this goal that I think that we all consider very important and precious right now. So I think, Lisa, with that, we can go ahead. Looks like it's about 1:40. We could probably go ahead and open things up. Heather and I and the whole PMT by extension are resources for you. We're available to answer questions. So let's do it.
So yes, so as a reminder, please put your questions in the Q&A feature. We have some questions coming in. The first question is basically asking whether or not the method for risk adjustment, if that's been finalized.
Yeah, so essentially the risk adjustment model that PQA developed has been sort of finalized and has been recommended to the Part D team. Now, the implementation of PQA measures and specifications in Part D is a process with moving parts. However, and I see this question, to be clear, the risk adjustment model has been developed. It is not still in development. So it is developed. If I'm not going to move through the slides, but the slide where I discussed how it's adjusting for age, gender, dual or LIS, and disability, excuse me. Those are the factors included in the model. And I don't know if there's anything, Heather or Lisa, you wanted to add there?
Not for me.
And then there's another question, Ben, that came in asking about the single weighting of the risk single weighting of the risk-adjusted measures when they're implemented in the STAR program. And I can move the slides back if that's helpful.
Yeah, I was just pulling them up on my end. But so essentially, first of all, there's always this this language problem when we talk about measurement programs and years, right? Because there's a program year and a data year. And so when we say 2026, do we mean a calendar year or do we mean 2026 STAR ratings? Because those STAR ratings are based on 2024 data, right? There's a 2-year lag. But essentially, because these, and I see sort of now been able to parse the question, because these are considered new measures and substantively updated, when they move into the STAR ratings in 2028, which is based on 2026 data, they're sort of considered these first year measures. And for that reason, they'll be single weighted.
Thanks, Ben.
Sure.
Another question is, when will PQA make the risk-adjusted model available to members?
Do you want to take that one, Lisa, or I'm happy to
Go for
speak
it.
to briefly? Yeah. So essentially, the risk adjustment model itself, and again, this gets to the implementation of the measures in Part D. The exact methodology for the implementation of it in STAR ratings, we expect will be sort of forthcoming as we move closer. If you've looked at the measure manual, you will see that we do have the recommendations in the sort of the footer for those who are members who have access to the measure manual about our recommendation for risk adjustment. But I think that what folks are talking about is sort of, can we have a formula or a piece of program that we can run that will sort of spit out our risk adjusted rates. And that is something that will only sort of exist once the implementation of the model is finalized.
Yeah, and I'll add on that the study that PQA conducted for CMS under contract is it's their work, and it's their work to implement within the program. And we do anticipate, although we cannot speak for CMS, anticipate that if the risk-adjusted measures are implemented through rulemaking, that there will be more information forthcoming from CMS. And another question we have here is, will risk adjustment be recommended for other PQA measures?
Heather, you wanna take this one?
Yeah, I'll take this one. So PQA really assesses the need for risk adjustment during our measure development. And so when measures are implemented in accountability or quality programs as well. And generally speaking, risk adjustments not considered appropriate for process measures, as Ben mentioned, where accountability entities have a higher level of control. And then for outcome or intermediate outcome measures, we do consider whether risk adjustment is conceptually appropriate in conjunction with sort of our technical expert panels and potentially with our risk adjustment advisory panel as well.
Thanks, Heather. There's a question about what is PQA's definition of health equity?
Yeah, I like that question a lot, Lisa, because it's, we talk a lot about health equity as a healthcare system, but it's always good to start with the basics and make sure that we have some shared or at least internally consistent definition of equity. And I would say that for the most part, PQA's definition and conception of health equity is pretty consistent with CMS's. So if you think about the CMS definition, they define it by saying health equity means the attainment of the highest level of health for all people, where everyone has a fair and just opportunity to attain their optimal health, regardless of their personal characteristics, so whether that's race, ethnicity, disability, sexual orientation, gender identity, and other factors that can potentially affect access to care or quality of care. So I think when we think about it, we want attainment of the highest level of health for all people, right? We want to raise the bar for everyone. And there's a couple of really good graphics around equity that some other folks on our team, and I'm thinking of Melissa, our Senior Director of Research specifically, there are great illustrations that sort of show equity. I know many people have seen the one with multiple sort of boxes and looking into the baseball stadium. But really, ideally, you're removing the barriers altogether and attaining that high level for everyone. I think that that's what we're trying to ultimately work toward.
Thanks, Ben. Let's see, other questions here. How does the proposed CMS's proposed health equity index measure and reward impact the PDC measures or vice versa? How does that interplay?
Yeah, I can take that one, Lisa. So the proposed health equity index would reward contracts for obtaining high measure level scores for enrollees with specified social risk factors, or SRFs. And so that index was really designed to create an incentive to reduce disparities in care, and measures that are case mix adjusted within the star ratings, such as what's been proposed for the PDC measures, would employ all standard case mix adjusters except for those that are the same as those SRFs included in the index, are those that are strongly correlated with those in the index or are conceptually similar. So essentially, if risk adjustment of the PDC measures is finalized, CMS would not include risk adjustment for dual eligible, low income subsidy, and disabled enrollees when calculating those index scores.
Thanks, Heather. And then there's another question that's getting at, a lot of people are curious about the methods used for risk adjustment. Maybe one of you can talk about give a little bit more detail about how risk adjustment was applied to the 3 PQA measures during our study.
Yeah, I'm happy to speak to that briefly. So really, again, and this gets back to what I was talking about, maybe I can go into a little bit more detail. Basically, once the risk factors are identified, right, these risk factor meaning a variable in the model, those are identified, first of all, through the conceptual model, through the literature review. The RAP actually chose to use multivariable logistic regression to evaluate. So those factors are going to be explanatory. The result is dichotomous. It's whether or not someone was adherent, thus the logistic model. This evaluation, basically what it's trying to do, right, is understand the empirical association between having a certain characteristic, for example, male or female, and ultimately being adherent to the measure. This evaluation was designed also to assess to what degree beneficiaries who are enrolled in the same contract have dissimilar outcomes. So to basically ensure that beneficiary comparisons were made within contracts, we did use a random effects model. So some of you may be familiar with the fixed effects models and random effects model. Again, looking within that same contract, we did apply a random effects logistic model, which really sort of controlled for the Part D contract in each measure, and this was done for each measure separately. So really what that did is acknowledge the variability in an outcome that is attributable to the contract, right? Different contracts are going to have a different effect on an outcome, and really focused on only making comparisons between beneficiaries that are in the same contract. And so what we then did was calculate a risk-adjusted score for each Medicare Part D contract separately, again, to determine the extent of the score change before and after risk adjustment. Again, for those of you familiar with risk adjustment, there's this sort of expected to observed ratio that sort of shrinks a measure towards the national mean. So essentially, for each contract, you have this expected measure rate, which is the average of the patient predicted probabilities. And some of this may be a little bit detailed for this forum, but essentially there's this expected rate, which is what your score is expected to be based off of your population breakdown, then your actual rate, and those are then combined and applied towards the national population rate to create a risk-adjusted score. So I'm going to pause there. So that was done for each contract. We did sort of look at that on a contract by contract basis in our study. But again, I'm probably going to pause. I think that we probably can't go too much deeper into methodology. That sort of explains how we established the model, right? But that's not necessarily the same thing as ultimately implementing the model, which, as Lisa mentioned, is going to be subject to rulemaking and the standard process that CMS uses to implement PQA measure specifications.
Thank you. That was a perfect amount of detail. And then we have time for one more question, and that is, does the risk adjustment of PQA measures impact plans' performance on the measures?
Yeah, so I'll take a stab at this, Ben, and then jump in. So it's really important to really just first understand what we mean by affecting performance. There's affecting a raw performance score, and then there's the impact that it has on a given quality program. For example, in Medicare Part D, shifts can be thought of at the individual health plan score level, as well as how that score translates into like a star rating. And so within our PQA analyses that only looked at measure rates as opposed to star ratings, we showed an impact on MAPD and PDP contract measure rates based on these shifts in deciles after risk adjustment using those identified SDS factors. And CMS actually also looked at this from a STARS perspective in the recently issued proposed rule, which was published, I believe, on December 27th, 2022. And so in that proposed rule, CMS proposed sort of implementing the PQA's recommended methodology for the SDS risk adjustment, which is a substantive change for the 2026 measurement year and the 2028 star ratings for PQA's 3 adherence measures that are currently implemented within the Part D star ratings. And so in developing this proposal, CMS conducted testing to assess the potential effects of SDS risk adjustment on star ratings for MAPDs and PDP contracts. So when a star level shift was observed, most of the MAPD and PDP contracts shifted by 1 star level, I believe, and usually shifted upwards when the SDS risk adjustment was applied to our adherence measures. Additional results from their analyses are actually described within that proposed rule. So I encourage you to pull that up and look through the proposed rule to see sort of the finer details of CMS's analyses.
Thanks, Heather. So now we're going to wrap it up with some announcements. We are very excited to be having our annual meeting in Nashville, Tennessee. So please join us. It's May 10th through 12th. We have fantastic speakers, educational sessions, and focusing on emerging trends in, of course, medication use quality, measure development, implementation, and care transformation. Early bird registration ends on April 14th. So please get that early registration in, and there's a link in the chat box, and then you could also scan the QR code on your screen. We also hope you will join us for a pre-conference workshop on May 10th. This is PQA's Medication Use Quality PQA Live CE event. It's accredited for 4 hours of pharmacist CE and will allow participants to engage with faculty, with our fine staff, in a question and answer session with dynamic group discussions. And there's a registration link on the slide, or registration link in the chat, and then you can also, there's another QR code there. And hopefully I'll have this slide up long enough for you to capture those. And then PQA also is providing scholarships for minority healthcare professionals to attend our 2023 annual meeting. Students who have completed their second year of study in pharmacy or other healthcare degree are part of minority groups who are underrepresented in quality are eligible to apply. And so individuals selected for a scholarship will receive complimentary registration to the annual meeting and the live workshop that I just told you about, 3 nights hotel, and a travel stipend. So we would like you to share this opportunity broadly. The self-nomination deadline is tomorrow on St. Patrick's Day, and you can use the link in the chat for more information. And finally, please join us for our next quality forum. That'll be Thursday, April 20th from 1 to 2 p.m. And the topic will be innovations in pharmacy to advance quality. And the registration link is in the chat. If you download the slides, which will be in the member portal within a week, there are references at the end of the slide deck related to the citations throughout the slides. Thank you so much for joining us today, and join us again in April.